Good evening, everyone. Welcome to tonight's Lung Cancer Living Room. All of you in the room, all of those joining us from online, welcome, welcome, welcome. It's great to see some familiar faces in the room and great to see some new ones as well. For those of you who do not know me, I am Danielle Hicks. I am the Associate Executive Director overseeing programs and services here at the Foundation. I am also one of Bonnie's daughters.
The oldest.
The oldest. The youngest is in the room somewhere, I think. I don't know. Anyway, we're thrilled to have you guys here tonight to talk about targeted therapy resistance. It's a huge, huge up-and-coming field right now. There's lots of really exciting things happening. There's a young one. She just walked in the back, in the back door. So we are thrilled to have Dr. Colin Blakely here from University of California, San Francisco, and Terry Kennedy, who you will meet for those of you who have never met her. She is a lung cancer survivor, and she's going to share her story with us. So thank you, thank you. Before we do the around the rooms, I want to, because sometimes she sneaks out before the end of the meeting, I want to give a huge thank you to Kim Shapoister for making the gravy, the bolognese tonight. She cooked all day in the kitchen and couldn't keep our fingers out of it. She kept having to come in and slap everybody. So thank you, Kim, for doing that. And then we do have a new employee here. So when it comes to and around the room, then we get to Dr. Amy Moore. I would like to make sure she introduces herself so that you can all get to know who she is. So with that, do I get a volunteer or do I just pick a person? How does this work today? Who wants to start? Anybody?
I do.
Oh.
Yeah. I just want to give...
You have a mic.
Okay. I just want to give a big shout out to Evie Schiffman. Some of you know Evie, not everybody, but her husband Neil had lung cancer several years ago and passed. And she was just diagnosed with lung cancer. No. Husband and wife. Terrible.
She's actually in surgery right now.
She's in surgery as we speak. She was supposed to start surgery at noon, but like all things that are supposed to go smoothly, as of an hour or two ago, she was still waiting to be wheeled in. So it's early, and we're all really excited for her and happy that she's getting her lung cancer caught early. So.
And I did want to point out for those of you who are familiar with the living room that I'm usually sitting here, but I have a bulging disc in my cervical spine, and it's pinching this whole nerve bundle down my arm. And I could probably sit for 2 hours, but it's the steroids I started this morning that are making me a little swimmy. I said, it was like an hour before this meeting, I said, I feel like the drunk girl at the sober baby shower. So I'm like, I don't think I should be on the panel today. So I will, however, because you all know I cannot keep my mouth shut, be chiming in from wherever I am around the room. Sorry.
We'll probably have to put a gag on.
I will apologize to my mom up front, because you know I will. So,
go sit down.
Yeah. So with that, if you guys could start the around the room, whoever wants to start, you go.
Okay. Thank you all for being here, and Colin, thank you too. We're very anxious to see your presentation. But first, we're going to go around the room a little bit so you kind of know your audience and how many people you're going to just wow tonight on targeted resistance therapies. So, Dave, you start.
I'll start. My name is Dave, and I was diagnosed in March of 2017. Stage 4 and adenocarcinoma, lesions in the brain, and a lymph node as well. Went through SRS, and I have been taking Tarceva since my, maybe 2 weeks after diagnosis. And the last scan showed, I had sent the email in to Michelle, actually, a little enlargement on the lymph node, as well as a little spot on the liver. Okay. So, but the spot itself on the liver doesn't look cancerous, they say.
Oh,
anyway.
Dr. Dave.
Right.
He's taking care of himself.
They're supposed to look one way and look a different way.
Yeah.
Anyway, so I did a blood biopsy, and through Guardant, the folks you introduced me to at the event last November, so thank you.
You're welcome.
And they've already received the blood, and it takes about 6 days. They're moving pretty quickly through these things, so I should have results next week. So I also want to share that I was in Chicago for the Chicago Walk, and we had a wonderful time. I grew up in Chicago, and of all the people, there was about 30, 35 of us on the team. There was one person who just shocked me to no end, and she's sitting next to me. It was amazing when she showed up. I had no idea. She just walked into Lincoln Park, and there we were all together. So it was quite a event.
That's awesome.
Anyway, I would suggest to any of you, if you haven't walked here in San Francisco, to join us, but even more so if you have, I would suggest going back to wherever you grew up, if you grew up somewhere else, and give that a try. It's a truly moving experience. This is where your friends and family from your childhood and maybe later on in your life are, and to see these people support you is pretty emotional and powerful. So anyway, thanks.
So
Thanks,
Dave, sorry,
Dave.
I'm already doing it.
there she goes.
Sorry,
Yeah,
I'm already
right.
doing it.
Yeah.
Okay.
Give her a
So
chair. Move over.
I don't know if you want to just share what you shared with Michelle and I, because I would like you to, what you did, because those types of opportunities are abundant for patients around the country and around the world.
The Tarsiva? So last
And if
year...
anybody wants to see it afterwards, go see it.
Last year, Nikki, who was the Genentech, I'm not even sure her exact position, but she would come to the living room most months, and she approached me toward the end of last year and asked if I would do a video for the Tarsiva sales meeting that they have once a year in Vegas. And it was going to be in January. So at the end of the year, they did a little video shoot. They had me from 9 o'clock in the morning till 4 in the afternoon, filming me, all for about a 4-minute video. And it came out, and they showed it to their entire Tarsiva team. Is there anybody here from the Tarsiva team? I don't know, any of the Genentech folks. But it was a tremendous experience for me, and they showed it, and it was successful. And, these kinds of things, as you say, they can be powerful to these people who are working for these drug companies. They need input from the patient. So I was glad to do it for them.
I'm just the wife, but I always like to jump in. I'm kind of like you. Anyway, just a little bit more on Dave's recent changes, and that is that his oncologist, whom we've already met with, has said that there's a very high likelihood he'll be moving to Tagrisso, which we all know that if he'd been diagnosed a year ago, he probably would have been put on for starters. And second of all, there's a chance they also may want to do radiation to that lymph node, just some radiation there. So that's kind of what we're waiting to hear the next steps on Plan B, although she had said, it's going to take probably up to 4 weeks before we get this approved and get it done and everything, but it actually looks like we're going to have it in about 7 days. So
Exactly. Come on.
because
Yeah.
when
No, we're not waiting for
he
it.
needs to jump, they all, how high. So
Good evening. My name is Don Stranathan, and I was diagnosed stage 4 lung cancer in June of 2009, actually June 23rd, so Thursday will be 9 years with stage 4. And I want to welcome Amy and Nicole. Nicole and I go back about 5 years. Penny and I had met her at a summit about 5 years ago. So, Bonnie, you're getting some good people.
They're coming. They're coming in droves.
Right.
It's good.
And I started on Avastin, Carbotaxol, Gemzar for my liver. And then back in 2009, they weren't really doing genomic sequencing. They just sort of gave me Tarsiva and said, well, let's see if it works. And it did. It worked very well for 6 years. And then in 2015, I had a new tumor in my left lung, had progression, did a Foundation 1 report, and found out I never had EGFR. So I reached out for a second opinion, started Opdivo, did 37 infusions until I had medicated toxicity in my periocardial sac, moved to Tecentriq, and now I'm on that new triplet of Keytruda, Alimta, and Carbo, and after 4 infusions, my tumors all shrunk 50%. So very exciting. And I'm also very excited, my friends are here tonight. For anybody that follows me on Facebook, John and I met John 9 years ago when I was diagnosed. He was in my bicycle spin class. And a woman, Judy, said, well, you got to meet John. He's got the same lung cancer you do. And John and I have been spinning together for the last 9 years, twice a week. And Sue, I ran into her mom in the mountains. She was hiking and I was mountain biking. And she said, it's amazing you can get up here on that bike. This is a steep climb. And I said, well, especially with lung cancer. And she said, oh my God, my daughter has lung cancer. Found out we were on the same drug. And 2 years later, approximately after surgery and everything, Sue called me when she was visiting her mom and said, "We're going mountain biking." So
that's
we've all
great.
become very good friends over the years.
That's great.
So, thank you.
Okay, thanks, Don.
Hi, I'm John, not Sue. So anyway, I was diagnosed in February of 2007, stage 4 adenocarcinoma. I've been through most of the various chemotherapies that are available over the years, meaning Carbo, Taxol, Avastin, Gemzar, Alimta, and in the summer of '07, actually went on Tarceva. Stayed on that for close to 3 years. Myself, as like Don, was EGFR negative, but it did keep me stable for 3 years. Shortly after that, participated in a clinical trial at UC Davis with Dr. Gandera, back on Tarceva with another drug, and that worked for another 9 or 10 months. Back to Carbo and Taxol for a couple more years, Gemzar a couple more years, then down to Stanford, met with Dr. Neal to see if I could qualify for a clinical trial for nivolumab, which I guess is now what we call Opdivo, but didn't qualify, didn't have the PD-L1 marker that they were looking for. The very same day, my doctor from, I'm from Santa Rosa, from Santa Rosa called me, Dr. Anderson, and said, "Good news." And I says, "How could it be good news? Dr. Neal just called 4 hours ago and said I was negative, I didn't qualify." He says, "Well, that may be true, but your foundation report came back and you're ALK positive." I said, "That can't be either, because 2 years earlier I had been tested and I was ALK negative." Needless to say, he said, you're going to be put on Xalkori, which of course I agreed. And 22 months later, stopped that due to some brain mets, switched to ceritinib, and January of 2017 switched to alectinib, and have been on it ever since, and I'm still on it. Much easier than the typical chemos, I will tell you that. It's a pleasure to be here. I feel like I'm in a room full of celebrities. I watch many of you on YouTube. And
You're the celebrities.
Yeah, thanks. I'll pass it along to Sue.
I feel the same. I've been watching you. So I was diagnosed with stage 4 lung cancer, adenocarcinoma, EGFR mutant, T790, in May of 2014. And I've been following Bonnie and her family since then. You've been a wonderful resource. I'm from Salt Lake City and was diagnosed there and being treated there. And again, big shout out. Thank you so much for all you guys do. I've been a real follower. Anyway, I was told to wait until we got the genomic testing, and I did test for EGFR, was put on Tarceva. Did well on that for about a year, and then we started seeing progression. The nivolumab trial opened. I went on that. Did terrible. A lot of progression on it. Was taken off that in 2 months. We tested for T790, and I was positive. So I got on the expanded access for osimertinib at that time, and then it got FDA approved, and I got benefit from that for about 22, almost 2 years before I started showing progression again. But the progression was just mostly in certain places. So we chose to irradiate those places. Weed the garden, they call it. My garden was weeded. But then we saw that we should probably try chemo. So I did get a couple doses of carbo and pemetrexed, and didn't do much, so went back on Tagrisso and looked for more weeds to grow and weed. And currently I've started Mine has been mostly lung and bone. And bone has definitely been a problem for me. And so I was put on Taxol just this last month, weekly Taxol, to try to address some of the bone pain that I get. So currently I'm doing that and still on Tagrisso. So very anxious to hear what you have to say, Dr. Blakely, about it. Thank you.
Thank you.
Hi, I'm Rick. I was diagnosed in February of 2015, stage 4 adenocarcinoma, being treated at Kaiser down in Sunnyvale. Basically, I didn't have any of the mutations at all, so I went straight to chemo. I had carboplatin Alimta for 4 cycles, and then Alimta only, and then had progression. But the carbo had taken care of the tumor in my lung and my lymph nodes, and so the adrenal gland that was progressing, they were able to remove surgically. And then I went on Taxotere for 4 or 5 cycles, and in February of 2016, I had my scan, and it came back no evidence of disease. So I've been clear for just over 2 years.
Wow.
And with all the chaos of getting to treatment and appointments and stuff, I retired. So I think that has added a lot to my disposition and outlook. So come here to get nuggets on how to cope and how to deal with progression, because I feel it's going to be coming someday.
Thank you. Tina. He never talks.
He's going to chime in anyway. He always takes the mic after you talk.
Right.
He'll grab it away.
Yeah.
My name is Tina, and I was diagnosed in November of 2010, and I did test positive for EGFR. My first line, though, I did start on Tarceva right away, but just for 2 months, and then I went to my first doctor was Tarceva. The second doctor was, maybe we should have done radiation first. The third doctor said, no, let's stop the Tarceva and do chemo and radiation. And that was the tumor board. And so I don't know, for some reason I felt good about that because it just sounded like really aggressive, and that's what I wanted to do. I don't know why.
Well, like if you were cancer, you had to have chemo.
Yeah, exactly. Anyway, here I sit 7.5 years later. I have, after my treatment, I did start on Tarceva as more like a maintenance kind of thing, and I've been on Tarceva for nearly 7 years, and it continues to work. And my doctor says, okay, well, what do you think? And he says, I just think we just need to stay the course. Don't rock the boat.
Right.
So that's what we've been doing. So
Okay.
I've been very fortunate, and I'm very grateful for that.
Rick. He told us all about your vacation. Yeah, that's good stuff.
I'm Sally, and I was found very early because I entered the IL-CAP study, which was to see if early people that were at high risk would be found sooner with low-dose CAT scans than with just regular X-rays. And I was at very high risk for getting it. And 5 years into it, one of my nodules grew, and I had my lower right lobe removed. It was non-small cell adenocarcinoma. That's 9.5 years ago. They're watching me because I have other nodules, although my oncologist, who I'm sure you know, Dr. Jahan, said to me at this point he feels if my cancer comes back, it's going to be a separate entity and not one of the nodules that I have. So I know on my mother it came back 3 times, so I wouldn't be shocked down the line, but I'm praying, and I'm praying Evie will be as lucky as I am because hers was found early.
She will be. She's going to be fine.
I'm Joanne. I was diagnosed stage 4 after a year of misdiagnoses in September 2016. Non-small cell adenocarcinoma with the EGFR marker. And I was put on Tarceva, which I've been on successfully 21 months. And the decrease in my tumor, and I had a small spot on the adrenal gland and quite a bit of bone activity, was dramatic in after the first 2 months, and continued even in the next 4 months to shrink and shrink, and now it's been stable, and I'm at 21 months. But what I really want to do today, that's my little story, is connect some dots here back to the stage of diagnosis, which some of you have referred to, but probably the scariest time in your life, like you just had a bucket of ice water thrown at you, and understanding nothing, where do I go, what do I do, even though the family's there, you have doctors. Well, at that point for me, I have a sorority sister whom I remembered was a lung cancer survivor. And our group still gets together every year or so, and she lives in Carmel. So I called Jackie McNamara, who's watching tonight, and Jackie is a friend of Stereo. And the first thing she says is, well, who's your oncologist? And I said, well, I was assigned an oncologist at PAMP. And she said, oh, you must have a second opinion. You absolutely must have a second opinion. You must either go to Dr. Gandara at Davis or Dr. Jahan at UCSF, and you must call Dario and talk to the daughter, Danielle, and she will set you up with an appointment. That's exactly the way she put it. And Jackie is kind of our go-to medical person in our sorority group. Anyway, so, okay, Jackie, I will do this. And I did call Danielle, and this was actually before I even had the EGFR marker part of the diagnosis. And Danielle actually set me up with 2 appointments, one with Dr. Gandara in Davis and one with Dr. Blakely at UCSF of the Jahan group. And because UCSF was closer, and the Blakely appointment was about a week sooner than the Gandara appointment, I chose to go with Dr. Blakely. And I'm so excited that he's here tonight. And my daughter Sarah is here, and my son-in-law David. And watching from Mexico is my sister Marion, and watching from New York is our son Eric.
Hi, Marion. Hi, son. What's your son's name?
Eric.
Eric. Hi, Eric.
So we're very excited to have Dr. Blakely here tonight, and he had revealed to me at my last appointment that he was going to be here. So I made it a point to be
That's
in
great.
California at that
That's
time.
great.
Well, I'm Ron, husband / caregiver of Joanne. I'm not quite sure what caregiver means.
It means you cook and do all the housework.
Well, I haven't done any of that.
And
I don't intend to.
Oh, no.
So about all I do as a caregiver is be sure she has her coffee in the morning, takes her Tarceva pill.
Okay, that's good. What else?
Am I getting there?
You're getting there. What else do you do?
And be sure the coffee's just right.
Perfect.
And then rub some medicinal ointment on her back in the morning.
I
and
like
in the
that.
evening. Has to be done twice a day.
That's awesome.
And that's about it.
Well, you know what? That's all pretty good stuff.
Oh, is it? Well,
Yeah.
it is.
Yeah.
But I also have to keep up with her, and we keep up our regular life. Keep going pretty quickly. We were in Mexico a few weeks ago with my sister-in-law, Marion Selly. Hi, Marion. Are you watching? She lives in Miguel de Allende. And we came back. We were there for a little over a week. Came back and here for a couple of weeks, and just returned last night from New York. And my son Eric. Hi, Eric. I hope you're watching. We were at the United States Open Golf Tournament up at Shinnecock Hills on Long Island.
Yeah.
And I had to keep up with Joanne. We did a lot of walking up and down hills, and had a great time. At the end of this week, on Sunday, Joanne is preparing for our granddaughter's 7th birthday.
That's huge. That's a big deal.
Hi back there. And there'll be 8 adults and 4 children. And so Joanne will be putting that little thing on. So, and I'd also like to introduce a little bit more carefully Sarah and her husband David, who's kind of sitting there, and he didn't think I was going to say anything about him, but there he is, son-in-law David, who is a Little League coach. Okay. And they finished their first season successfully. And they're now into a second season. Thanks, David. And that keeps us really going every weekend.
That's
and it's
awesome.
wonderful.
That's
so
awesome.
we're very, very fortunate and appreciative of Dario and what you people do and what we hear around the living room.
Thank you. Thank you. I think maybe we'll start over here and then we'll go around the back and then we'll get to our folks later.
I'm Ken and I'm a caregiver of my son. And she was diagnosed with EGFR stage 4 last year, and we got started on, Bonnie refers to Dr. Gandara and got the foundation testing and then got on the appropriate treatment for the L858R. And since then, 2 Garden 360s are negative. So just got our fingers crossed that they keep coming back negative. And look in the future. It's perfect.
That's awesome. Thank you.
Hi, my name is Dr. Joseph Jans. I'm an orthopedic surgeon from Phoenix, Arizona. I was diagnosed in October of last year with stage 4 with metastasis. After going 1 round of chemo, I kind of made the decision I couldn't go through any more chemo. I don't know anyone here who felt the same way, but I thought it was horrible, and luckily had both PD-L1 and ALK-Phos positive receptors. I've been on Alecensa since December 1st, and then subsequently had to come here because my wife threatened to divorce me. She's friends with Don on Facebook and follows him all the time, and he actually helped her quite a bit, indirectly and directly. Otherwise, whoever made the pasta pasta is fantastic.
Thank you. Come on, Fred.
Yeah.
What's up?
Can you see me?
Yeah, we can see you.
Okay. My name is Fred Palmer. I was diagnosed with non-small cell lung cancer in October of 2013, and I'm currently on immunotherapy.
And doing well.
Yes, so far.
Doing good.
Yeah.
Yeah. What kind of immunotherapy are you on?
I'm on Keytruda.
Keytruda.
Right.
Okay. Keytruda. Thank you.
Hi, I'm Larry. I was diagnosed in January 2013 with stage 4 non-small cell adenocarcinoma. I'm on my 3rd round of treatment, Plan C. I'm on Tagrisso, and I'm a constant watcher online, seldom attendee here, but a huge fan of this foundation.
Larry, I'm just, sorry. Larry,
Okay.
Larry, like many others, is a huge volunteer and does a ton of work and helps us in ways that go beyond anything anybody should have to do, like others in the room as well.
Right.
But Larry's not here in person often, so I just wanted to say thank you in person.
Thanks, Larry. I won't take up much airtime because my dad covered most of it, but I'm the daughter.
And then
give you our whole family story and everything we do on the weekends. I am Joanne's daughter, and I just want to thank Bonnie and Danielle and Michelle and everybody who has supported me through this journey. When my mom got diagnosed, I too was very scared and lost, and finding you guys was extremely helpful for me and my husband and our family to navigate this. And I, just to kind of tie it back to Dr. Blakely, I can't say enough about people who have been recently diagnosed about getting a second opinion, because it just made a world of difference and continues to help us validate things we hear, take different avenues that we would not have thought of otherwise, just having the capability or the ability to have a second opinion. So I encourage anybody who's going through this to reach out to other through other avenues and not just take the first answer you get as the right answer, because every step along this journey, my mom has come against various roadblocks and things that we thought we couldn't get through and things we thought we couldn't fix, and we've found that there is an answer. It's just not always the first one you get. So thank you, Dario, and thank you, Dr. Blakely, for being here tonight.
I just want to, sorry, again, I know. I just want to, just kind of to tag onto that a little bit, how important the second opinions are. And sorry, I know, and I'm doing it from here. I should have just left the chair up there. How important second opinions are. Sometimes there's a lot of people diagnosed in this country and around the world who don't have close access to the, Dr. Blakely's of the world. But if you can get there even just one time and have a good sort of treatment plan brought up that you can then bring back to your community physician and talk to them about having your treatments done in your hometown, that's an option for a lot of patients too. So I just want to throw that out.
Thank you, Danielle. Yes.
Hi, my name is Karen. I was diagnosed actually in late 2007 and had surgery in January 2008 because I was so fortunate, only a 1B. My tumor was found completely by accident and was a non-small cell adenoid carcinoma. And I had 4 cycles of chemo. It was cisplatin and gemcitabine. And since then, I've been so fortunate to not have recurrence, and I'm watched every year, but I was also very fortunate to have Dr. Fred Marcus as my doctor. He's so very special.
Yep.
And missed by so many. And I think that Bonnie was just starting the foundation. I didn't even hear about it till several years after I had gone through treatment and everything, but I'm hoping to be able to do more volunteer work as I go forward, trying to cut back on my work life and give more time to the foundation. I just think it's fabulous, and you're doing so many amazing things. I just wish you all well and keep going.
Thank you, Karen.
Okay, so I'm going to interrupt now.
Okay, are you going to talk about Fred?
Well, I'll definitely talk about Fred, but Karen, when she first was introduced to the foundation, she snuck into the gala. She didn't actually sneak into the gala, but she kind of came in under the radar. And so we kind of had to poke and prod and ask her how she found out about us, but continues to support the foundation and now wants to support us in other ways of helping us through our ambassador program. Fred Marcus was truly one of the most remarkable oncologists ever. He dealt with my family, which is a tough one. We would all storm into his room, and there is a picture of him right up here.
Right there.
He was a local oncologist here who
Right there in the
back
corner.
in 2003 was kind of thinking ahead of the game. And because my mom was treated by him, at that time she was really given a multi-D care when it didn't exist for lung cancer. And in 2006 or 6, he was diagnosed with stage 4 lung cancer.
And I was taking care of him. It completely turned around, and it's a really sweet story. He had surgery somewhere along the way, and I said, Fred, you're going to need a special chair because it's going to be really hard to sleep at night because when you have this amazingly invasive surgery. So he says, I don't need a chair. Rah, rah, rah. So he got out of the hospital and he was home, and I was talking to him every day. And I said, how are you sleeping? He says, I'm not sleeping at all. I said, what do you think about the chair now? He said, I think maybe that chair would be nice. So we had delivered one. It was one of those chairs that like lifts you up off the ground and gets you going, but also very comfortable. He called me and said, Bonnie, this is the best night's sleep I ever had. But then what he did is he also apologized to me. He said, I just didn't know. I just didn't know what the patient goes through until he actually, went through it himself. And that stuck with me forever because I think it's something, that should be on every physician's mind. what would I do if I was in these shoes, or what would I do if one of my children was in these shoes? So, but God bless Fred Marcus and you, Karen. Thank you.
Well, real quick, Bonnie, Debbie Marcus is online and said,
"Oh, come on,
you're warming
that's
her
his
heart
daughter."
by mentioning him." So, just thought I'd put that out there.
Fred's sister.
Oh,
Yeah.
wow, crazy.
Hi, I'm Claire. I'm Terry's youngest daughter. I'm home from college for the summer, or for a couple weeks, so thought I'd use this opportunity to come and check out the school scene. I didn't know much about it coming into it, to be honest, but yeah, so nice seeing you all and meeting some of you, and yeah, thanks.
Hello, I'm Colleen, Terry Kennedy's oldest fan. Just kidding. She's actually my older sister. I don't think she was my fan until I was about 18, but the sisters here understand that. So I'm Terry's caregiver, although I do not make her coffee. And I'm also co-captain of the Sacramento 5K this weekend, and currently Team TKO is the lead team. So I agree with Dave, come back to your hometown and have a run and see what you can do. So
There you
really
go.
because of Terry, but we've got
Awesome.
the run on Saturday, and I'm here to support Terry tonight.
That's awesome. Thank you. Thank you.
We probably don't have to have all the staff introduced.
Well, yeah, let's start with Katie. Is there anybody over here? We'll just introduce our staff really quickly.
But really quick, everybody.
Really quick. Katie, what do you do? Don't.
Hi, everybody. My name's Katie Wilcox, and I am the Senior Manager of National Events. So I'll see all of you at an upcoming event, I'm sure, if I haven't already. And Saturday in Sacramento. Try to beat Team TKO.
Danny.
I'm Danny. I'm on the Emeritus Board, as well as I'm doing the Legacy Program for the Adaria Lung Cancer Foundation.
I'm Jennifer Hughes, Director of National Events, and thank you guys for all being here. I think I've only missed 2 of these since I started, so it's so great to see you guys all here.
I'm Sandra, and I work with the Lung Cancer Registry. If you haven't joined, join the registry today.
Hi, Nicole Phipps-Petras. I'm the Director of Community Engagement, and as Don said, I'm new-ish to ALCF, about 2 months in, but I've worked in lung cancer advocacy for 7-ish years, so happy to be here.
I'll stand up so you can see me. I'm Amy Moore. I'm the new Director of Science and Research. So by way of background, I have a PhD in microbiology and immunology, but trained as a cancer scientist as a postdoc at Vanderbilt, and then am fresh off the plane from Georgia. I just moved here this weekend. So in Georgia, I was connected with a statewide cancer initiative that had been founded by a previous governor using some of the state's tobacco settlement dollars to help move the needle on cancer outcomes. But this is a real pleasure for me to get back to my cancer roots, to be connected to the science, and most of all, to be connected to all of you, the patients, and to do the work that we do to help you all. So I look forward to being connected with you. I'll be in that seat next month talking about the best of ASCO, so look for me next month.
Straight off, literally straight out of unpacking boxes and off an air mattress. And right,
I would love to be unpacking.
sleeping on an air mattress. So,
Hi guys, I'm Katie Skilsky. I'm on the events team here at the foundation, so I'll see some of you on Saturday in Sacramento.
Hi, good evening, everyone. I'm Leah Fine. I'm the director for the Centers of Excellence program. So I hope that everyone here has access to a multidisciplinary care team. And if you don't, please come see us.
Hi, I'm Gina Tallarico. I am the West Coast Events Manager, and I will see you all in Sacramento.
I'm Jan Alott, and I'm the Senior Manager of Marketing and Communications, and it's wonderful to see all of you here and be spreading the word about lung cancer and your experience. Thank you.
I already went.
I'm Andrea Parks. I work with, I kind of wear many hats here, but majority development and partnerships here at the foundation. And definitely, most importantly, the younger daughter.
she's the young one. So now I'd like to introduce.
In the corner, sorry.
Oh, sorry, Michelle.
I'm Michelle Zay, and Patient Services and Programs, and I know most of you, almost all of you.
Now I'd like to introduce Dr. Colin Blakely from UCSF. and he's going to talk to us about progression and resistance and why all of those things are happening.
Great.
And what we can do about it.
Thank you so much, Bonnie, and thank you to you and your organization for inviting me. You know, you are definitely a legend in the Bay Area and now nationally, and I'm just thrilled to be here. So thank you so much. And you know, I'm inspired by all the stories. Many of you have been fighting lung cancer for years and some even decades. So it's about you. That's what makes me do what I do, to try to help you and to improve the therapy. I think if we just stick with the status quo, it's not enough. And I've kind of dedicated my whole career, much of my life, towards improving lung cancer treatments and coming up with, hopefully, some of the next therapies, or at least being involved in that. So today I'm going to talk about overcoming resistance to targeted therapy, in particular in lung cancer. So over the past decade or so, we've begun to understand lung cancer, in particular non-small cell lung cancer, and I would say more specifically adenocarcinoma at a much more defined molecular level. We've been able to determine that there are key mutations within the genetics of the cancer that seem to be critical for driving the cancer's growth. They're addicted to these genes and these mutations. And as such, if we can find drugs that can target them, in many cases we can cause these tumors to shrink, in many cases shrink dramatically and for long periods of time. I would say that's been most successful with EGFR, as some of you have talked about, as well as ALK, which makes up a smaller piece of this pie, but still very important. And there's been now at least 3, and actually 4 FDA-approved drugs to target EGFR, and another 4 to target ALK. And these have been huge advances. However, these treatments almost always stop working at some point during the disease course. How do we overcome that? So first I'll focus on EGFR, and that's really my, I would say, area of expertise and what I spend most of my time studying, although I do have interest in ALK and other targeted therapies as well. But EGFR stands for epidermal growth factor receptor. So it's a protein made by the gene that goes to the surface of the cell, and it responds to signals from outside of the cell and tells that cell to grow and divide. And it's a very important gene, a very important protein. It's made in almost all of our cells in our body. However, when you get a mutation in that protein, the cells no longer need that cue from the outside. They no longer need a signal from another cell saying, okay, it's time to grow. And they just do it automatically. It's basically like a light switch. You just can't turn it off. Fortunately, we have developed drugs that in some cases can turn it off. And those are effective most against these L858R and exon 19 deletions, which make up the majority of EGFR mutant lung cancer. However, as many of you know, and many of you have actually experienced this, at some point, these drugs stop working, and we get what's so-called acquired resistance to therapy. And that's when you move on to new drugs such as Tagrisso or chemotherapy or immune therapy. What we're finding, however, is that that's a harder and harder disease to treat because there are not just a few mutations, say EGFR maybe plus a handful of others that are driving the tumor's growth, but maybe there are dozens of mutations in the cancer at that point. Maybe there are what we call subclones present that have additional mutations that the initial tumor didn't have. So our focus at UCSF, and I'm partnering with Trevor Bavona, Dr. David Jablons, and others, is to understand what's happening at this initial response to treatment. Why is it that the tumor usually responds but doesn't go away completely? Definitely you can have complete responses to therapy, but I would say they're pretty rare. So why is it that the tumor is persisting? What can we find out about it at that point and maybe target before it even gets to the point of acquired resistance? And that's really the major focus of my work at this point. One of the ways to understand this better is to get access to the tumor DNA at pre-treatment at this kind of residual disease state and see how it evolves over time to become a fully progressing acquired resistance tumor. And we do this in part by doing biopsies of the tumor itself. But as you guys know, sometimes that's very challenging and can be painful, and sometimes we don't get adequate tissue to analyze. So what I've done is I partnered with Guardant Health who many of you are familiar with, to do liquid biopsies on patients, and was able with them to get access to their database of about 1,200 EGFR mutated lung cancers, and to do a thorough analysis of what's happening at this, even before treatment, that might be influencing how well somebody responds to an EGFR inhibitor, what's happening during treatment, and what's happening at resistance. And what we found is that this cancer is much more complex than we had originally realized. So it was initially thought that, well, if we just find the one mutation that makes it grow, that's all we really need to know. But in reality, there are dozens of alterations frequently in these tumors. And we really need to know what's happening in every one of those pathways and what role it's playing in the cancer's growth and progression and resistance to therapy. So to do that, I looked to see how patients did, and I correlated it with what mutations we found in their plasma, in their what we call their cell-free DNA, or circulating tumor DNA. And we found a number of mutations actually did correlate with worse response, in this case to osimertinib or Tagrisso, in different pathways. And I'll zero in on something called the cell cycle. And the cell cycle is what tells the cell to make a copy of itself. It's very tightly controlled by multiple proteins and pathways within the cell. And when that gets altered, the cell can grow out of control. We thought that maybe EGFR signaling was enough to do that, but it turns out if the tumor also has an alteration in one of these cell cycle genes, that it's even more aggressive, and in this case, resistant to osimertinib in many cases, in the patients that we've looked at in this study. So how do we potentially overcome that? Well, we're working right now to develop a potential new therapy. We're doing this in what we call preclinical models at the moment. That means in the laboratory, testing cancer cells in Petri dishes, and also in mouse models of cancer to see if this therapy will work. And we're working with drug companies to take this to patients to develop a new clinical trial and hopefully change what is the standard of care for treatment of this disease. And that treatment would be a combination of osimertinib with what's called a CDK4/6 inhibitor. So CDK4/6 is one of these key factors in the progression of the cell cycle. And we found that that gets altered in a lot of these cancers. Fortunately, in the breast cancer world, they've already developed a drug against that. So we're hoping to kind of repurpose those. Actually, 3 of them are now FDA approved. We're hoping to repurpose that drug for lung cancer. And it's started to be studied in lung cancer and it hasn't really had a lot of traction yet. But that's because I don't think they're studying it in the right population. They're just studying it in every patient. I think it's only in the patients that have specific alterations where you're going to see a benefit. And I think you're going to need to use it in combination with other therapies, not just by itself. So what I'm proposing to do is to use it in combination with osimertinib, with the idea that we can shrink the tumor and maybe even get some of these what we call complete responses, where the cancer goes away completely, with the idea that that's going to delay the time before the cancer begins to grow again. We're trying to basically kill more cancer cells from the get-go. Another way that we're focusing on this problem of disease persistence is to actually get access to tissue at that persistent state. As I mentioned, biopsies are challenging at that point, and it is putting a patient through a procedure that they don't need clinically, but really purely for research. And that is hard to come by, and many patients have volunteered to have that done, and we're very grateful to them. But another way to do this is to do it in patients that are already going to have that tumor resected anyway through surgery. So I've partnered with AstraZeneca and David Jablons at UCSF. He's the chief of thoracic surgery there, for those that don't know him. And what we're doing is a clinical trial to identify patients that have early stage EGFR mutant lung cancer. This could be up to stage 3A, which means they have lymph nodes on one side of their chest. And we're going to treat them with Tagrisso or osimertinib for 1 to 2 months prior to surgery. And the expectation is that that's going to cause the tumor to shrink, but not completely. And so what we'll have left is this residual disease that happens in many patients. that we don't understand. But Dr. Jablon's then will go in and he'll remove the tumor, and then we'll have it to study. And we'll be able to do any of a number of things. We'll be able to look at the transcriptome, what's called the RNA of the tumor. We'll be able to look at what genomic changes have been selected for by the drug treatment. We'll be able to look at what immune cells potentially come into the tumor and either are trying to eliminate the tumor that's left over or are actually helping the tumor to survive. The tumor is very crafty in a way. It can recruit immune cells in to give it growth factors to allow it to survive inhibition of EGFR. So this will allow us to understand all of those things, and then once we understand it, then we can target it. Then we can come up with new combination therapies. And that's our hope that this study will be.
What's the benefit to the patient? Because this is stage 3?
Up to stage 3. It could be stage 1 to 3.
Mm-hmm. But it's not really usual to do surgery on 3.
For us at UCSF, I would say it is.
Well, I know that because I was one of them.
Yeah.
But everywhere else, it's not really necessarily standard of care. So the benefit to the 2 months of therapy is, what is the benefit to the patient other than
so
research?
I think there's several possible benefits. One is that we could downstage the tumor because we think that 80 to 90% of patients with this EGFR mutation will respond to this treatment. The tumor will shrink.
Okay.
So we could downstage it from something that was borderline surgically resectable to something that's much easier for Dr. Jablons and his team to resect. We're also going to look at what's called pathological response, and they've done this in breast cancer for years. They really have this program of doing what are called neoadjuvant clinical trials. And they're looking for combinations that lead to complete elimination of the tumor. And they've correlated that with patients who do well after surgery. They live longer, their cancer doesn't come back. So hopefully we'll be able to identify what characteristics would lead to that, and then in those that don't, what characteristics of the tumor are allowing the tumor to persist and not completely go away.
So is this is different than the Alchemist trial in that is in the adjuvant setting?
Correct.
Right?
Yeah, this is before surgery.
Yeah. I just want to remind everybody, too, if you have questions during the presentation, please just grab your mic. You don't need to wait till the end to ask your question.
And I would also say that in many cases, at least at UCSF, and I think in many academic places around the country, we do more of this neoadjuvant therapy than we do adjuvant therapy a lot of times. We do it before surgery, and Dr. Jablons has been a huge proponent of that for years because he feels that, one, you can downstage it, and two, if he has a better chance of getting all of the tumor and getting good resection margins, it makes his job and to get all of the cancer much easier, and he can also take less of the lung. He doesn't necessarily have to take 2 lobes. Maybe he can take 1. Maybe he could do a wedge resection instead of a whole lobe. So that's the advantage of this. And I would say that we traditionally would treat these patients with chemotherapy before surgery because we don't know that osimertinib works in this setting. But chemotherapy only works about 50% of the time. This, we think, will probably work 80% of the time. So it could be a big change for EGFR mutated lung cancer and how we treat it in the earlier stages.
Well, Dr. Blakely, aren't they also doing clinical trials right now for immunotherapy for early stage, and they're getting great success with that also, correct?
Absolutely. Yeah, there was a paper published in the New England Journal in April that looked at just that thing using Keytruda, or pembrolizumab in this case. There they exclude patients with EGFR mutations because it hasn't been proven to work as single agent therapy in that setting. But they did see some of these complete pathological responses when they do that. We actually have a trial developed by one of my colleagues, Matt Gubins, and Sue Yam, one of our radiation oncologists, to do a combination of a small amount of radiation therapy in combination with pembrolizumab, nivolumab, Opdivo, in that neoadjuvant setting, with the idea that the little bit of radiation, it's not full dose radiation, but the little bit is going to stimulate the immune system a bit. It's going to wake it up. It's going to expose it to these tumor antigens. So we have that trial open as well. So we're, all of our patients that have earlier stage lung cancer, And stage 3 lung cancer is still any lung cancer is a very serious disease with a high chance of coming back. So we have trials for basically all patients with early stage lung cancer to treat them with either targeted therapy or an immune therapy approach. So that's this trial I was mentioning and what we're going to do. Beyond that, we have collaborated with, we as in Trevor Bavona, myself, and some of our colleagues at UCSF, Saurav Bandyapade, Eric Collison, have developed a collaboration with the Stanford group, which is great because UC and Stanford don't always play nicely together. So we've been finally able to bring us together for a common goal and a common cause. And that's working with Calvin Kuo, Heather Wakely, Suki Pata, and their team down there to do some of these biopsies that we were talking about in this so-called residual disease setting. And this is what we call our Bay Area Team Against Resistance, because it really does take a team to make this work. So what we're doing is and this is in the metastatic setting now, not in the early stage. What we're doing is we're identifying patients who have either a targetable mutation, such as EGFR ALK, or who plan to go on immune therapy with PD-1, Keytruda, Opdivo, et cetera. And we're consenting them to this clinical protocol to undergo a research biopsy prior to treatment, and then a second biopsy after an initial response to therapy. And we're comparing those two biopsies through multiple different modalities, looking at all of these things I talked about, genomics, immune cell infiltrates. We're also growing the cells that we get from the biopsies in 3D organoids, which are basically growing the tumor cells in 3D to make a 3D tumor in a Petri dish. And that technique was really pioneered by Calvin Kuo down at Stanford.
And aren't you just like creating a little organ?
Basically, yeah. A little tumor that's growing in your Petri dish. And then we also can implant it into mice to do more animal studies that are, I think, more recapitulate what might happen in patients. But we were just getting started on this. We've been doing this for about now 6 months or so. And we've had many patients volunteer for this. I'm very appreciative of that, but certainly we need more to better understand this disease. Now, we've talked mostly about kind of what do we do at this disease persistence state. Well, what do we do about acquired resistance? What happens when the tumor is actually growing again? It certainly is an active area of research for me. It's something I'm still very interested in. We don't know a lot about Tagrisso resistance at this point. It's still early. We're seeing some of the common pathways in BRAF, HER2, and some of the others, MET as well, that are all targetable. But as I said, many times the cancer has multiple different mutations present, and it's hard to target all of them. So how do we possibly overcome that? And this is not my work. I won't take credit for it, but it was really exciting to see this presented at ASCO this year. And that's the study, what's called the Empower 150 study. And this took patients who were being treated with first-line therapy that have metastatic, what's called non-squamous, non-small cell lung cancer, so adenocarcinoma primarily. And instead of treating these patients with chemotherapy, they received chemotherapy plus the drug called bevacizumab or Avastin, which targets the vasculature of the tumor. And randomized patients to receive either that or the combination of chemotherapy, Avastin, plus immune therapy, in this case the drug called atezolizumab, which is another one of these PD-1 type inhibitors. In this case, it's actually a PD-L1 inhibitor. And what they found is that across all patients, that quadruple combination, they actually lived a lot longer, several months longer. Now, we obviously want months to turn into years, but it's certainly a start and very impressive that their data did show this dramatic overall survival benefit. But what was particularly striking to me is that this was one of the first studies that allowed EGFR or ALK patients to also enroll in the study. They allowed them only after they had progressed on their usual targeted therapy, so erlotinib, osimertinib, alectinib, that sort of thing. But they allowed them nonetheless. And these are patients that were going to go on to get chemotherapy more than likely. And what they found is when they used the immune therapy combination, you can see that upper blue curve, those patients are doing fantastic for many of them. And they're still, many of them are still alive and doing well compared to the patients that just got chemotherapy, clearly not doing as well. And so this is, I think, going to really change what we're doing and how we're treating resistance to targeted therapies. You now have a way to potentially awaken the immune system up against these tumors that traditionally have not been very immunogenic and responsive to immune therapies. So this is really exciting data, and hopefully we'll hear more to come on this. So just want to, in the last couple minutes, switch gears to ALK. This is something I'm also very interested in. So ALK is it's not a receptor, but it's a gene fusion. So what happens in ALK is that you basically have the DNA in one part of the cell breaks off and connects with another part of the cell, and it's just not, these two genes are not supposed to be together. And what happens when that occurs is that you get massive expression or massive production of this protein called ALK. And that can signal through similar pathways that EGFR can to drive the growth of the cancer cell and turn it into a cancer. This was discovered now going on about 10 years now, and it's really been amazing the pace of drug discovery here. We had crizotinib approved in 2011, and quickly thereafter we had another drug, ceritinib, and then alectinib, and now brigatinib, and then we expect lorlatinib to be approved soon as well. So these are all potential drugs that can target ALK and cause tumors to shrink. However, like EGFR, the problem is that resistance still occurs, and these tumors don't go away completely. In many cases, we can identify the mechanism of resistance through what's called a second mutation in ALK that causes the cancer cells to become resistant to that targeted therapy. But as you see in the white there, about half of the patients, you can't find anything that's causing resistance. So why is that? How do we treat that? Well, one possibility is to look at how ALK signals. What are the downstream pathways from ALK? Maybe it's one of these pathways that gets altered that's driving that resistance. And ALK is known to signal through multiple pathways, what we call the PI3 kinase pathway on the upper, the STAT3 pathway, the RAS pathway, and the PLC gamma pathway, among probably a dozen others as well. Which one of these is actually important to this tumor? We didn't know. Until a graduate student in Trevor Bavona's lab did a very elegant study in which he used genetic approaches as well as drug approaches to systematically go through every one of these pathways and figure out which one ALK was truly dependent on. And what he came up with was that MEK pathway, that MAP kinase signaling pathway. And fortunately, there is a MEK inhibitor that's available. There's two, actually. One of them is trametinib, the other cobimetinib. And in a mouse study, he found that if he just used the drug ceritinib, which is one of these second-generation ALK inhibitors, by itself, he got nice tumor shrinkage for a while, but then after 60 or so days, it started to grow again. Very similar to what happens in patients, only on a kind of compressed time scale. But if he started treatment with ceritinib and trametinib from the beginning, all of the tumors were eliminated and never came back. So we've seen, these dramatic responses in mice before, so I don't want to get too excited about this, but it was really intriguing data. And to the point that I worked with Novartis over the last 2 years to develop a clinical trial to combine ceritinib with trametinib, and that study is now open at UCSF, and we're accruing patients to that. So if any of you are interested in that study, I'd be happy to talk to you more about that. So I think with that, I probably use my time, and I'll just thank you. And none of this work could be possible without you guys. So you volunteering to participate in the research is just tremendous, and thank you for that. And just want to thank the rest of my team. And Bonnie, early on, the foundation funded me back in 2012 when I was a fellow. So kind of started me on my way. So I'm very thankful to you for that.
You're welcome.
Thank you.
I think there's a couple of questions online. So go ahead, Michelle.
So someone was asking, are they discovering possible future resistance with second biopsies? Can they know resistance will happen before it is discovered by tumor progression?
Yeah, so we're working on that now. We've now biopsied about 30 patients at that. They're still responding to treatment, and the tumor has not started to grow yet. And we're just doing the analysis now. It takes a lot of effort to get the genomics done, and we're doing what we call whole exome sequencing on these tumors, as well as whole RNA sequencing on these tumors to understand what's allowing them to persist. And I do predict that we will find mutations that are eventually going to be the resistance mutations that are present even before the tumor is progressing. I predict that will definitely be true.
What do you see in the future, 5 years from now?
For lung cancer in general, or this space, I think that the immune therapy is definitely going to be continued to improve upon. I think we've seen patients have dramatic responses to that, but not enough. We've only seen about 20% of patients are responding to immune therapy. And if we can find a way to make that work for more patients, for all patients really, then I think that's really the goal. In particular, for these EGFR, ALK, and other targeted therapy patients, if we can find a way to understand what the role of the immune system is in those patients and to harness it to fight the tumor instead of what I think the immune system is actually doing, just helping the tumor in that case. If we can find a way to actually make it fight the tumor, then I think we'll improve therapy. And I think in 5 years, we can definitely push the survival of this disease out past a decade. That's really what I see.
Okay.
So I have a question, and we heard it in the room tonight, and we hear it all the time about, well, my original biopsy didn't show anything, so I went on chemo or did whatever, and then eventually, for whatever reason down the road, I had another biopsy, and now I have the ALK.
Right.
Or I've actually met patients who were thought to have EGFR, did really well on Tarceva in spite of the fact that you didn't have the mutation, and then their cancer switched to an ALK. What role well, first of all, why does that happen? And I guess my second question is, what role do good quality biopsies play, solid tumor biopsies play?
Yeah, I think that's a great question. So there's this process or this entity called tumor heterogeneity. The tumor is not just one thing, and if you biopsy one spot, you may get something completely different than if you biopsied another spot. Now we think that there are some common, what we call truncal events of the tree that are common among all the cancer cells in a patient's body, such as EGFR, such as ALK, such as KRAS. Those are definitely unusual stories when you see it once and then it disappears and you see something else. But I really think it's that tumor heterogeneity issue that you may get a completely different result if you biopsy the lung tumor instead of the liver tumor in a patient, or the bone tumor instead of the brain tumor in a patient. So really, it's a challenge, and making decisions on just a really tiny piece of the puzzle is hard. Things like Guardant and Foundation that have their blood-based tests, I think, do probably a better job of capturing that heterogeneity, and they identify other mutations that a single tumor biopsy wouldn't have. The problem with those is they're not quite as sensitive as the tumor biopsy itself. So, meaning that they may only detect 80% of the EGFR mutations in a patient that had an EGFR mutation in their tumor, for example.
But if and when the liquid biopsy base when it advances and is more sensitive, then it would technically not only be better for the patient, but kind of get rid of that heterogeneity problem.
I think so. Yeah, I think that's, to go back to Bonnie's question, I think that's where we're heading as well, less biopsies. I know we talked about our study doing biopsies, but I think clinically we're going to be doing less biopsies because these tests are already very good and they're just going to continue to get better.
And do you know, is there a scientific reason why, or do you have a hypothesis as why somebody would jump from one mutation to another, and or even from an adeno to a small cell?
Sure. So I think in a case where somebody had, say, I had an EGFR and then it turned into an ALK, I think that was probably two different clones present from the beginning. Maybe the EGFR clone was the dominant clone. It was 99% of the tumor, so you never were going to find any ALK in that tumor. But as soon as you started treating the EGFR, the ALK was free to grow, and that's what you found. So I think that's probably what was happening there. We've seen that in a couple of cases that we're hopefully going to report out. And then the small cell transformation, that's a huge problem to me. It doesn't happen in a lot of patients yet, but as we get better and better about targeting what's making the cancer grow, it's finding ways around it. It's finding, well, if I just change what I am completely, you can't target me anymore. And we can't target small cell right now, unfortunately. So why that change occurs, it's probably still genetic loss of genes like P53 and RB1, which probably are two of the critical things that happen that allow that cancer to now transform into a completely different type of cancer.
So before we get to Terry and she tells her story, I just want to make sure we answer everyone's questions. Don, I see you with a mic, and we got some in the back too.
I just got a quick statement because I was on Tarceva for 6 years, and when I had progression in 2015, I reached out to a oncologist research at the University of Colorado.
Yeah.
I was asking about an NTRK without fusion, but I said, well, could I have ever had EGFR? Because they never tested back then in 2009. And he asked me the question, he said, did your tumor just stay stable or did it shrink?
Yeah.
And I said, no, it just stayed stable all those years. He said, you probably never had the EGFR mutation.
Yeah, I think that sounds like the right description of what happened there. Is your tumor was still somewhat dependent on EGFR signaling. As I said, that all of our cells have EGFR, and sometimes tumors can make a lot more of it, even though it's not mutated. So yeah, I think that's probably right.
For people who didn't have mutations at the beginning and then progress at some point after other therapies, is there a chance that they've developed those targeted therapy, those mutations that targeted therapy might be useful?
Yeah, I think that is possible. I would say we're still learning about the genetics of those cancers and what kind of is happening at resistance. There's a genetic alteration in KRAS, which many of you have probably heard of, which if that's present, it's going to be very difficult to treat anything else that might develop if we're not targeting that. And I think the good news there is that there are now new drugs that are coming out in clinical trials coming out that target something called SHP2, which seems to be critical for KRAS's ability to drive tumor growth. So for any of you that may have a KRAS mutation or know people that do, keep a lookout for those studies coming forward.
But do you ever recommend like these liquid tests for people who are failing on a current therapy?
For me, I always want more information as the treating oncologist. I feel like the more I know, the better I can actually come up with the best treatment for the patient. So otherwise, we're just guessing at what might work. It may not be helpful, but it might be. So I always recommend getting more information.
Terry. I have a few questions.
Sure.
So, going over more how to treat once you have resisted, sounds like a lot of your work is trying to understand what causes resistance. So going back to the CDK4/6 that you showed, what do you think of that in the instance of treating people that have resisted?
That have it, yeah. I think we would try it there, absolutely. And it's possible it would work. I also think that it might even be better if we used it earlier in the disease, if we can identify those alterations earlier before they cause resistance and go after them.
But yeah, no, I think don't have the luxury of
absolutely, totally understand that. And yes, I think we would try it there, and I think there's a good chance it could work in specific patients.
No, is what you're talking about in a clinical trial type drug, or is this the existing breast cancer drug?
So there are 3 FDA-approved drugs. I've had patients that have had alterations in these pathways that I've tried to get those drugs for. Sometimes insurance allows it, sometimes they don't. So it's kind of hit or miss right now. We are going to be having a trial from Novartis in the next 3 or 4 months that I think has one of those as part of its arms. So it'll be something to keep an eye out for.
And then, so more questions. So a common resistance mechanism for EGFR is C797S, which you didn't touch on. Is there anything that you're aware of that's kind of focusing on targeting that as a resistance mechanism, or that?
Yeah, interesting. The C797S is another mutation within EGFR that makes the tumor resistant to Tagrisso. And So it's not quite as common as the T790M was. It's only maybe 20% of resistance seems to be at least in part driven by that. But also we're seeing it's usually not just C797S that's present. It's HER2 amplification, it's BRAF mutations, it's others. So it doesn't seem quite to be
the
dominant driver. Now, in terms of how to treat that, there is some suggestion that either gefitinib or erlotinib can target that, only if there's no T790M mutation. So patients that started on Tagrisso from the beginning of their disease and weren't treated with erlotinib or gefitinib can develop that as a resistance mutation to Tagrisso, and then you could potentially treat with erlotinib or gefitinib. The patients who started on erlotinib or gefitinib and got the T790M and then went on Tagrisso, at resistance, they still have that T790M, so it's unlikely that that would be beneficial to switch them back to erlotinib or gefitinib, if that makes sense.
Okay, a few more questions. So
No problem.
the study that you're showing from ASCO with adding immunotherapy to the chemo regimen as being successful for both people for ALK and EGFR resistors. How do we continue on that momentum? Because it doesn't make a lot of sense when EGFR isn't, sensitive to immunotherapy.
Right.
So
well, first of all, I think we still need to use these targeted therapies first. I think that's clear. There was a study that looked at using Keytruda before targeted therapy, and they saw no responses. So we still need to get the most out of our targeted therapies. And one idea I think that why the tumor might respond better to immune therapy at that point is it has developed a lot more mutations that the immune system can potentially recognize. We're hoping to partner actually with Genentech to do a study to biopsy patients at resistance to, say, Tagrisso or alectinib, and understand which patients benefit from this quadruple combination versus which don't, and what are kind of the key factors. It's probably not just PD-1, is my guess, or PD-L1. There's probably a lot of other things at play. And in the patients that don't benefit from it, why? That's the question we're trying to answer.
You didn't mention CAR T cells tonight.
Yeah.
What do you think of that?
It's interesting because my wife is a hematologist, so she actually uses these in her practice. She's also at UCSF.
Okay. Should we call her?
Yeah, we should call her and see what she thinks. So far, it's really an intriguing idea, obviously, and it's been very effective for certain types of lymphoma and certain types of leukemia. But you have to know exactly what the key antigen is that the tumor is making to go after. And so for lymphoma, that's a molecule called CD19. So if you just make your T cells target CD19, you take them out of the patient, you engineer them to target CD19, and you grow them 1 trillion-fold and put it back in the patient, and they just kill everything that's CD19. We don't know what that is in lung cancer, what the key thing to go after is.
But there is a test to see if a patient would respond to CAR T cells.
For the liquid tumors, for lymphoma and leukemia, we don't know yet enough in solid tumors how that's. And people are definitely studying this in laboratory, but I think it might be a little bit beyond 5 years before it's ready for solid tumors, unfortunately. But hopefully it will be one day soon.
Okay.
I know Terry has more questions, and I still want you to tell your story. But
Yeah.
I have a question you made me think about something when we were talking about, since Tagrisso has been approved first line, and then the way you explained it, would it make sense for an EGFR patient who didn't start on Tagrisso but has yet to progress to switch to Tagrisso before they progress?
Say that one more time?
Yeah. What?
I see.
So I'm an
Tarceva.
EGFR patient, and my first line was Tarceva.
Yep.
And I haven't progressed yet.
Yep.
But now Tagrisso's maybe a better option. Does it make sense before I do progress to switch back to a...
It's a really great question, and I take it on a kind of a case-by-case basis. If somebody's been on Tarceva for 5 years and they're still responding to it, I think somebody said you don't mess with that. If they have brain metastases and they've been on Tarceva for 6 months and they have kind of a stable-ish disease, maybe a little bit of a response, then I'm switching them. So it kind of depends on the patient.
And my second question was, there's so much variation in the time to progression in these patients.
Yeah.
Is that due to aggressiveness of tumor? Like, what do we know why?
Yeah, well, part of that was what I was trying to look at in that study. What's happening outside of these key drivers? What's happening outside of EGFR? And we're just looked at we're scratching the surface because the Garden study only looks at 70 genes. So if you look at 20,000 genes instead, you're going to find a whole other slew of factors that might be allowing some patients to go 10 years before their disease progresses, whereas others are only going 6 months. And we don't fully understand that. One of the things I think is those cell cycle alterations. But we'll see if that pans out.
Bonnie mentioned the CAR T being, and you were saying it's almost too specific. What's your feeling on vaccines that are being developed? Are they going to be too specific to get all the heterogeneity that you're seeing?
Yeah, I haven't seen a lot of success yet in the solid tumor vaccines. I know there's a lot of enthusiasm about this so-called Cuba vaccine. If you look at the data, it's actually not that strong. And I think if it were a paper that was published in the United States, it wouldn't really have gotten that much press. So I think there's still interest in it for sure, but to have a vaccine, you have to identify the key antigen to go after, and we still don't know. Yeah.
So I'm in a pre-trial for Genentech, who's pairing with BioNTech, and they are they've actually looking at normal cells and the mutated cells, and I'm wondering if that holds any hope.
Yeah, I think that's a great approach. I know that there were, for those of you that didn't see the breast cancer patient report in the Nature Medicine a couple of weeks ago, basically they did that. They identified what was different about the tumor cells and then identified T cells that could go after those changes, and then they took them out and they grew them in the lab again, and then they re-injected them in the patient. And they basically took a patient with metastatic breast cancer, and now she has no evidence of disease. Now, we don't know if she's cured or not, but a very impressive response. So I think something like that might be sooner to be developed than the pure CAR T cells.
Dave?
Can we go back to what you had mentioned earlier? If you are on Tarceva and you're starting to show some progression and they're going to be switching you to Tagrisso, and you had said if it had been about 6 months or give or take, that you would definitely be switching them, especially if you had lesions in the brain. And why would that be?
So this is minus T790?
This is right. Okay. T790 doesn't show up yet. Now it may, I have a blood biopsy coming this week, the results, so maybe it's there now, but it wasn't in the original, correct?
Right. So the reason I say that is the benefit of Tagrisso, there's two major benefits. One is it can target T790M, and the second is it crosses the blood-brain barrier much better than Tarceva does. So and Tarceva does to some degree, but Tagrisso is really specifically engineered to do it. So it's just a better penetration into what we call the CNS.
And that's why it's gone to first line.
Yeah. That's why I would use it in the first line. And that's why we will see an overall survival benefit to that drug once all the data is read out. I'm quite sure of that, but we'll see.
So to kind of go a little forward with that, if you've got lesions in the brain, it would make sense to...
Yeah. I think in most cases it would make sense to switch from Tarceva to Tagrisso if you have lesions in the brain, even if they're controlled.
Even if you're not seeing progression.
Yeah.
Right.
I usually recommend that for my patients, and if I can get insurance to do it, I usually do that.
Okay. Thanks.
Terry, your story, you thought you were going to get away without it, but you're not.
Okay. Like everybody else, I have a lung cancer diagnosis. Not everybody, but a lot of folks here. I was diagnosed in August of 2015, so coming up 3 years. I've had a lot of experience with resisting targeted therapies, so that's kind of unique. I've done a lot of lines of treatment, and that's why this is very interesting, and I can share my experience with trying to come up with ideas to deal with the resistance. So I started out after diagnosis and having I had a very large tumor on my upper right lung that I think was like the size of my fist, and progression or metastases to my bones and some lymph node. And so, because it was considered to be growing at a fast rate, before I even got the genomic testing results, I went on a chemo and did that, just a pemextred and carbo for 2 rounds. And in the meantime, I got the results that I was EGFR. So we went ahead and waited to see if I responded to the chemo. I really didn't respond. It didn't grow significantly, but there wasn't any shrinkage as a result of the 2 rounds. So we switched to the targeted therapy, which I, at the time, did afatinib shortly after diagnosis. And I was a super responder to afatinib. The tumor shrunk to the size of a dime, is from what I understand. And it went away in my bones and no spread. But I responded tremendously, but not for very long, like 8 or 9 months. And then new nodules started to appear.
Yeah.
And I never had that stable period. It was just like shrink and then, yeah. So after having a tissue biopsy after showing some growth after afatinib, T790 showed up, T790M. So I went on Tagrisso, and this was close to a year after being diagnosed. Moved to Tagrisso. Let's see, one scan after being on Tagrisso, I think was okay. And then the next scan, and I do scans like every 6 to 8 weeks. I'm a pretty frequent scanner. And the second one shows some growth again. So I really did not respond that well to Tagrisso, which I think of another question. You talked about why some people don't respond to Tagrisso, and I don't know if that has to do with as a second line or a beginning line or what, but anyway. So I never know why I didn't respond to Tagrisso. But so after that, I had another biopsy which showed C797S, I believe. And the T790M went away. But, again, it was maybe a different part of a tumor and that whole thing. So I became a clinical trial junkie after that, trying different things. And, I didn't think I wanted to do chemo. I was trying to push it off. I wanted the targeted therapy to work or some combination. So then I'm treated at UC Davis with Dr. Reese, and he was principal investigator of a trial that's been pretty successful with necitumumab plus Tagrisso. And so I tried that, let's see, about a year and a half ago almost, and I had a very toxic response to the necitumumab, a very unusual, and actually I don't have very many side effects, and I've taken a lot of different drugs, but for some reason, I don't know if I was allergic, but I had to drop out because of toxicity, so didn't really get an idea of how that would have worked for me, but it... Tell us how that manifests itself. The toxicity? Sure. Well, I was actually hospitalized for low heart rate. I was getting dizzy, and my heart rate dropped, my blood pressure got extremely low, and I, at the same time, was getting a really bad rash where like my skin burned, and they couldn't figure out the source, and that caused me like my temperature dropped really low. So it was just like the combination of everything, and couldn't seem to get out of the cycle. Finally, they got my heart under control, which I never had heart issues before, never had any bad response to a medicine. So I got that under control, but the rash thing was really still a strong issue. It wasn't just like a rash that we treated. They kept trying to figure out the source of it, and it was I finally went to a dermatologist at Stanford that specialized in oncology dermatology, and I went on an antibiotic for a month, and I did bleach baths to get rid of it. I mean, it was like a staph, and I don't know. Yeah. So it was just, the quality of life was horrible from it, and I couldn't maintain. I tried it a few times, spreading out the treatments, and it was just too harsh for me. So, and my medical team agreed that it was not a good therapy. So, but I was a very unusual case. I don't think they ever saw that before. It was like, how they have the percentages. So this can happen, but it was like left turn. So, and then I tried a combination of Tagrisso and Tarceva to see if having both at the same time might, and did that a couple months, and it still had some progression. And then I did some radiation to like three nodules that were because I was still not as bad as when I was diagnosed. It was, progression every time, but it was, I didn't have many symptoms or anything. And so I wanted to try radiation, did that, and I don't know if that was actually successful or not, because shortly after that, I became really short of breath, and it turned out to be pleural effusion. So there was progression happening probably before the radiation. Whether it was the right timing or not, I don't know. But so the pleural effusion caused a lot of shortness of breath, and that was tested a lot, the fluid. And there was some MET that thinking that was maybe a driver. So I went on, tried 2 different trials with a MET inhibitor combination with Tarceva, and I progressed on both of those. They were at UC Davis as well. And so this was at the beginning of this year. It was definitely, I had C797S, T790M show up, and EGFR in my blood. So I think that indicates resistance to targeted therapy, basically, when you see all that. And so
that's a lot.
Yeah, and it's so, and really, it was chemo, and I thought, well, I've been keeping in contact with an immunotherapy expert oncologist in LA, and thought I would try a trial before doing chemo, because I really, it was a risky, long shot, but the hope that in immunotherapy it might work was very hopeful. So I tried a trial with Keytruda mixed with 2 other drugs that were supposed to light up my immune system, being EGFR, to hope it worked, and it was with drugs called Gitter and epacadostat. But that combination, after 2 rounds, I could feel the symptoms again, my chest tightness, short of breath, and so we knew pretty quickly that that wasn't working either, and was progressing pretty quickly. So within the same week of finding that, within a few days, I switched to a chemo combo of paclitaxel, Avastin, and carbo. And went off the targeted therapy. I went off targeted therapy at the beginning of the Keytruda combo trial. So we don't really know if that pretty fast progression was a result of just going off targeted therapy, or one of the immunotherapy drugs causing it. So at any rate, I agreed to switch to the chemo combo a couple months ago to do 4 rounds. I did 4 rounds of that, and after the first 2, the scan showed quite a bit of shrinkage, like around the 30% or so. So it was, and I was told going on it that it was like a 30% chance of working. So I'm like, oh God, going through all this hellish treatment and for a 30% chance. But anyway, so I had a good response to that, and then did 2 more rounds. So I did 4 rounds total, and there was even more shrinkage. And I just started maintenance of Avastin and started back on Tagrisso.
Okay.
So that's what I'm doing right now. So we hope, and my doctor thinks, we can ride out the Avastin for as long as we can. And that's another question, is this idea that going off TKIs and then re-challenging them, how, is there any science to that as a possibility for...
Yeah, it's an interesting idea and approach. There's not a lot of data on that yet. I do think it could make sense because a lot of times the faster growing tumor cells are the ones that don't actually have a lot of resistance mutations. The more kind of oncogenic mutations the tumor has, a lot of times it grows slower, believe it or not.
Yeah.
But it's just resistant to therapy.
Right.
So if you take it off, you're off Tagrisso for 6 months and the tumor grows again, it could be sensitive to it again. That's possible.
Yeah. So I'm, keep trying different things as a result of being progression, but it's not, progression out of control necessarily. Right. There was some as a result of the immunotherapy trial, it grew pretty fast, but still in the boat. So I want to also say that there's so many of us in the world that are been on Tagrisso or Tarceva and developed resistance. So about a year ago almost, I was talking with a research scientist, and just 'cause I do a lot of research and about ideas, and he was saying that, and I was kind of frustrated because he had some drug he was working on that might be successful, but he was saying, how difficult it is to get to clinical trials and how frustrating it is for patients, like in my boat, to what's coming down the line. What can we, especially after going on targeted therapy and seeing the success of that, and seeing immunotherapy successful for some forms of cancer and wanting it to work. So so talking with him and made me think, well, what about us all that are resisting or potentially resisting, grouping together and seeing if we can provide information to researchers and oncologists to try and find some more therapies. And so I talked with a gal that in upstate New York who I had been partnered with as like a mentor or a support person. Never met her in person, but we talked on the phone occasionally. And she is a great patient advocate, more so than me. I sort of live my life, and then as I learn more, I'm like, okay, I got to get more involved. And so she knew a lot of people, and we came up with the idea, well, we need to band together and try and help push research. So we formed what's called the EGFR Resistors. And she was so great that she knew of a few other advocates in the Boston area, in Chicago. And then I got my sister Colleen involved, who's been great, and she's been got the whole website developed and got us all signed up. And so there's like over 500 of us now, and we're working with Bonnie and have been for several months to try and come up with a research project that's going to make sense for us and to make progress on this, serious issue that for all of us that are resisting the target EGFR targeted therapies and what we're going to do and try to save our lives, basically.
Exactly. We're doing PDX models on mice.
Yes, we're starting.
And, with as many patients as participate, and then using multiple different drugs and look to see what's working, what's not working. And actually the patients will be able to opt in to actually get information and talk to their therapist about
Sounds like a great
possibilities.
Yep.
So,
yeah.
I just had a question. You've had a lot of treatment, and I'm assuming you've had a lot of testing, and it sounded like you had progression fairly quickly on immunotherapy. Sue and I have discussed this, but I know maybe Dr. Blakely can weigh in more, but with the MDM2 or 4 mutation, that can cause, what I've read is it can cause hyperprogression.
Right.
I was wondering if you ever tested for that.
It did not show up on my genomic profile. I do have a low tumor burden, is that what you say? Yeah. So I didn't know that, and I didn't have any PD-L1 expression or extremely low, so I did know that. But I did not have, I think Sue has that, and I don't know, if they considered it hyperprogression necessarily, but it did progress quickly. Didn't have a response.
I just want to point out how unique and awesome it is what Terry has been able to pull together for the EGFR resistors, to be able to get that many similar patients together and agree to go out and be involved in research is a huge feat. And our clinical trials wouldn't be weighing as low as they were if more people were doing what you guys are doing. And there's groups out there for ALK as well, and for ROS1 and whoever else might be watching, interested in some of these groups that have pulled together. And we're working with all of them in some capacity, and it's just truly, truly remarkable. So thank you for that.
And we actually had a call with Colin and Trevor about the organoids.
Right.
And, we're not stuck on doing just one thing.
Yeah, we're kind of feeling around right now to figure out what
to look at other
behind,
options. But it's, a clinical trial accrual is one of the biggest issues out there. So for these patients to be pulling together and creating these groups, you won't have to do so much fishing. They're going to be coming to you, and saying, I need this many. And, even into the submarkers, it's not just about EGFR, because you might say, I need 10 exon 20s, or I need, various different things. So,
And we feel like we're still trying to grow our community, and the more people we have, the more data available, and to coincide with a lot of what you're working on. And we know we're not all starting from scratch, but we could provide a lot of information about our treatment history and our mutations that would maybe drive some research. Oh, look at all this, the number of percentage of this showing up, and these people also took this, and some informative information that we're hoping to help.
No, that's great.
And will be. I have a question for you, Colin, because I'm just a huge believer in patients being a big part of the solution. And I constantly talk to everybody I have an ear to, that clinical research, we always call it from the bench to the patient. What do you think about transformational research and call it from the patient to the bench and back to the patient?
Yeah, I think that's what we refer to it as. I agree with you that bench to bedside. I actually think for me it's the reverse.
Right.
I learn the most from the patients. I think I learned that early on in my training, that being in the laboratory, you can only learn so much from treating cells in the petri dish.
Right.
And where I was learning the most was from the patients I was seeing in clinic, and that's why I actually kind of switched from being a lab-based scientist to being more of a clinical translational scientist. Because I learned the most from the patients, and that's why we did that garden study. We tried to learn, and you're exactly right. We need that information about how you did to the therapy that you were on. What other treatments you've had. It's a big puzzle to put it all together.
Right.
So absolutely. Completely agree with you.
And we have a patient registry where the patients can put their own information in for patient-reported outcomes. And as the registry gets bigger and bigger and bigger, eventually we'll be able to connect with the EMRs and validate the data. But data is the key. It's the key.
Absolutely. There's Foundation and Garden and all these other companies, or even the internal sequencing, that there's just tons and tons of data, but a lot of it's not connected with how the patients did.
Exactly.
And so it's only so helpful. Right. We can kind of understand, but you don't really know.
We need to know how long a patient lasted on a particular, everything that Terry just talked about. That's all critical.
Yeah, I mean, we feel like a lot of us patients that we're in our own doctors in some ways, because there isn't a standard of care. We're trial and erroring. We're out there, and there's so many of us patients that are so knowledgeable because of this.
Absolutely.
And that's why we're kind of banding together. It amazes me every day the amount of knowledge of the people that come out of this group.
I love it. I love it when one of, I call them our patients, that are listening or participating or what have you, when they go to a physician. Dawn knows what I'm talking about, and the physician says, well, what can I do for you today? And then they start asking questions, and they start saying, well, I'd like to know about that clinical trial, the number 1.004, and the physician says, who are you talking to? Where are you getting all your information? Well, they're gathering it from,
I learn from patients all the time. They come in and say, hey, have you heard of this study? I'm like, I haven't. I better read about that.
Right, exactly.
Absolutely.
Exactly, yeah. They're doing this real time.
Well, I always like to tell people that, any oncologist, even if they specialize in lung cancer or whatever, has so much to know and to learn. And I always say we only have one job. Our job is to learn everything possible about our kind of cancer.
Exactly.
And that's why we can completely focus, and we can't say, well, the doctor should have known. It's our job to do that, right?
Right. We're in charge. We're in charge.
I have a question. Back to the Tarceva-Tagrisso question. For those of us who have been successfully on Tarceva for a long period of time, if the side effects became really bothersome, would you consider switching to Tagrisso?
Absolutely. Yeah, and I've done that for patients before.
You have?
If they get too much of a rash or any other toxicity from the Tarceva, then I would absolutely be willing to switch.
I need to talk to you then. I've got the scalp thing going on.
Come back and see me.
Any online questions? A lot of chatting?
It's actually perfect timing, so we only have about 10 minutes left to do our thank yous and all that stuff on your sheet. Did you want me to?
Okay. Would you like to do it, Danielle? Or?
I have a funny story to tell, though, after all of this.
Okay.
Because we have like 30 seconds for me to talk about me. I just walked down to use the restroom, and Arash is down there talking with Kim. And both of them said, Danielle, will you get rid of spiders? And I was like, oh, hell no, right?
Right.
But it was huge, and it was dropping right down the ceiling. Well, my adrenaline kicked up, and I forgot that I had an injury. I took off my flip-flops and went to town on it. And as soon as it was gone and my adrenaline went away, I was like, that was so stupid. I don't even know what happened. So the key to me feeling better is spiders, apparently, is what I'm saying. Yeah.
Well, we all thank you for not having to deal with the spider tomorrow.
It was a tarantula. It was huge. Yeah, no, it's gone. I got it.
Well, we'd like to thank Dr. Blakely tonight, UCSF. Big round of applause. Amazing presentation. Terry, we didn't let you hide. You probably thought, oh, they're going to keep going and I won't have to talk, but you were amazing.
Thank you.
And, I mean, look at her. She has had all of these treatments, and look at her. I mean, if you didn't know, you would think she was just doing fine, right?
Mm-hmm.
So, thank you.
Thank you.
Thank you. Now we can't close down the night without mentioning the Sacramento Run this Saturday one more time, June 23rd. Where is it? Where's
William Lynn Park.
Oh, thank you. Okay, awesome. And then July 15th, Napa to Sonoma Wine Country Half Marathon. Quite a few people doing that. Next living room is going to be Best of ASCO, Dr. Hatim Hussein, UC San Diego, and Amy Moore, PhD, ALCF. We had her running around Chicago for days on end and nights on end, learning everything that was new in lung cancer. We have another event August 2nd in Hollywood, Florida, August 6th in Denver, Colorado. Remote living rooms. Well, but you didn't put it on here.
The irony is we have to stop calling them remote living rooms because when we're in Denver, they're not remote to the people that are coming.
Okay.
Right?
But what we're doing, we have this every month, come hell or high water. But Danielle and her team are going out on the road in between, and they're going to various facilities that we're working with, and obviously UC Colorado is one.
And Arizona's on one of our tours.
And Hollywood, Florida, which is Dr. Luis Reyes. And August 21st, Advances in Molecular-Based Therapy. Heather Wakely will be here. We always have a crowd from when Heather's here because her entire support group comes, and that's awesome. And then what is this? Stanford. This is Danford University. Heather.
That's where Heather
Stanford.
is. Yeah.
Thank you. Right. She's now at Danford University. It's just down the road. And big thank yous to the Office Bar and Grill for bringing us food month in and month out. And wine comes from the Addario cellar right behind this door. Everybody helps themselves like they were personal owners of it.
Yeah.
Right.
It's
part of the job. Part of the job. Thank you most importantly, always first and foremost, to our patients, to everyone in the room, everyone online, and everybody in the world that has lung cancer. We're always here to help. We're here to, get you second opinions. We're here to do whatever you need done. And then our sponsors, we can never forget AbbVie, Amgen, in alphabetical order, AstraZeneca, Boehringer Ingelheim, Bristol Myers Squibb, Celgene, Genentech, Lilly, Medtronic, Merck, Novartis, Takeda, Yahoo Employee Foundation. And this list keeps getting bigger and bigger because these people love that we are helping them educate patients. They believe in smart patients and they want smart patients, and they're totally supportive of what we're doing here. So, thank you to, and Danielle's. The San Francisco.
I don't have that on there, Joanne.
When's the San Francisco
it's in September.
5K?
September.
I know it's in September.
23rd, I think. 23rd, 24th, or 25th. Dave's saying no.
Dave, when is it?
I think it's Saturday the 29th.
Oh.
Yes. Amy's, I think it sounds like, yes.
I think it said the 23rd.
Okay.
And it went to Saturday the 29th.
And you don't look at me. I don't know. I couldn't tell you. Apparently no one knows.
Wait, there's a flyer right here.
Okay.
Maybe.
Okay.
Yeah, I don't know.
But as soon as
all
we
of our
get,
events teams already started to clean up.
As
the
soon
kitchen,
as we get the date, I just would love to share it with you that it is the most wonderful day for patients. It's our biggest run anywhere. We even have a police escort. We're so big. But we have tents and people come and they cook and they bring their kids. We have runs for the little ones and it's an amazing day. It really is an amazing day. And, 29.
29.
Okay, awesome.
I just wanted to mention I put save the date cards on the tables. I'm doing a Celebrate Sobriety with a grassroots event with a Dario. It's next June, so don't show up this weekend or we'll put you to work. But it's out at a ranch in Winters. And, so we're going to be celebrating, all sobriety. I mean, not sobriety.
Survival?
Never mind. Survivorship.
Not to be the lung cancer living room. Not to be confused with an AA meeting just because of the wine.
I'm done.
Right. I can't come if it's about sobriety.
What I was going to say, because we have a couple of minutes left, is that, and I know my sister and my brother and everybody that works at the foundation will agree with me. I mean, I want
Jared's
to give
working
a
here?
Jared, no, my brother's not coming.
Oh.
Your son's not here. We love Jared. He's not. You're never going to see him here, though. My mom, since birth, has brought hope into my life. Just hopeful to be, human and for my future and all of those things. And I just think I want to thank you for not only what you've brought to me in my life, but what you bring to all these people and the people I meet around the world who lead with how hopeful you are and what you bring to them in their fight. And it's so, so, so huge and so important. So thank you. Thank you for letting me be a part.
Thank you.
Oh, and Sally. Thank you to Sally for bringing the dessert.
Oh, Sally. Yes, Sally. And Peninsula TV. Jeez, Louise. Thank you. You can tell she's getting to be an old timer. And what about Penn TV?
Yes, a huge thank you to Penn TV. Seriously, for those of you new here in the room and online, they come out every month, and it takes them hours to set this up and to break it all down. And they do an absolutely amazing job. And then they will play this on the local TV channel all month long until the next one comes out.
The whole night they play, and then it gets edited and goes into our library. But if you opened this door over here and saw what they bring and what's behind, I mean, they're creating a TV production here. They're amazing.
And sadly,
look,
because we are not
crazy.
tech savvy.
Look at the people back there.
Half the time we get here, we're like, Rocky, the internet's down, or we lost the cable. And he's just like, and he puts up with it every single time. And a huge thank you to my team, especially Michelle, who put in a lot of time putting this living room together, the brand new debut night of the living room. It's been a long, long time coming, and we have been bargain shopping. And I haven't been any help with moving furniture and stuff. So a huge thank you to all the team for helping me do that for all of you. And now
looks nice.
Okay, so I'm getting a glass of wine. I don't know what you guys are doing.